A very good afternoon. My name's Dr. Deb. I'm one of the consultant paediatric gastroenterologists at the Royal London Hospital, and I'm hoping that some of you will have joined me today to have a teaching session on pediatric inflammatory bowel disease. So I'm hoping to, in the next hour, talk to you and give you a general overview of pediatric IBD and really talk to you about some of the differences in adults compared to children, and with that also talk about the importance of why we need to make very prompt diagnosis of IBD, and also really how we manage it, some of the things you can do in primary care as well as in secondary care. And lastly, I wanted to make this talk interactive, although I'm not sure that I'm going to be able to be very useful in this. See any bits of where I could see if questions come up at the moment, but I will try and do some case scenarios, time allowing, at the end of this talk. So to start off with, inflammatory bowel disease, by that we call it IBD, and obviously it's not talking about irritable bowel syndrome, which actually a lot of our IBD patients do have as well. It coexists. And what we talk about when we talk about inflammatory bowel disease are three separate entities, really. The first is Crohn's disease, which is a condition that affects any part of your GI tract from the mouth to the anus. Secondly, ulcerative colitis, which is a condition that really is limited to your large colon only, but can sometimes cause a backwash ileitis and involve some of the small intestine. And then the bit in between, where some of our cases, it's not straightforward and you can't tell the difference between Crohn's and ulcerative colitis, and they're what we call the indeterminate colitis, and the ones in between, when some of them end up being ulcerative colitis and through their disease course, but initially we're not able to decipher which one it is. Now, when it comes down to what causes IBD, well, and a lot of research has been done to try, really this is multifactorial and find the causes of this, but we think it's all to do with you. And to count now, there are almost 200 genes that have been implicated in the pathogenesis of IBD. But over and above just your genetic predisposition, we think that your mucosal immune defense system, so both your innate immune system as well as your adaptive immune system, are almost attacking the gut due to environmental triggers such as your luminal bacteria or exposure to infections. And so therefore, because there are so many multifactorial etiologies that encompass into it, we really can't single out any one causative factor when it comes to the cause of IBD. In terms of IBD in pediatrics, this is becoming more of a pediatric disease where a quarter of the cases are diagnosed before the age of 16. Most of the children who we see will have a diagnosis of Crohn's disease, which is more commonly seen in childhood than ulcerative colitis. And the other way that IBD differs in pediatrics is that IBD tends to be more severe of a phenotype than adults at its onset, and the degree of colitis is much more severe in children. Now, in terms of the incidence of Crohn's disease, well, at the moment, the data isn't really that different from, say, 20 years ago, where Crohn's disease tends to be in 2/3 of our children with an incidence of between 2.2 and 6.8 cases per 100,000. And a third are then ulcerative colitis, with maybe 10% of them being indeterminate. And then you've got the adult figures here as well. You can see from this slide that whilst the incidence of ulcerative colitis, apart from in Scotland, has been fairly steady, the incidence of Crohn's disease is sharply on the rise. Now, the symptoms of IBD are multi-system really, but the common symptoms that you will see in inflammatory bowel disease is you may have loose stools with diarrhea that may or may not contain blood and mucus. Certainly you will see that a lot more frequently in ulcerative colitis, although a really bad case of Crohn's colitis can present in exactly the same way with bloody diarrhea. You can also have children with growth failure, weight loss. And again, this tends to be more commonly seen in Crohn's disease as opposed to ulcerative colitis. But again, a very severe ulcerative colitis patient can also have both of these. A real differentiating factor is the presence of perianal disease. Now, we don't see this in ulcerative colitis because it is a condition limited to the large colon, whereas in Crohn's disease, you will see this. And therefore, it's really an important part of the examination is to look at the perianal region and have a chaperone as well when you're doing this. The other common symptoms are obviously abdominal pain, which is present in both Crohn's disease and ulcerative colitis, anemia, and this can be a chronic anemia of a chronic inflammatory condition due to low iron stores. It can be a microcytic anemia to get oral aphthous ulcers in both of these conditions. And then you can have the extraintestinal features of an arthritis, fevers, and generalized symptoms of inflammation. Now, I wanted to stress the importance of growth in pediatrics because obviously this is where pediatricians come into play when you're talking about IBD in childhood. And that's because growth is so important in these children. A, because they have a chronic inflammatory condition that is stopping them from achieving their full growth potential. And B, because when we treat these children, we want to ensure that they catch up in their growth potential. So faltering growth occurs in up to 40% of children with Crohn's disease. Again, the etiology is multifactorial if you think that this child probably is nutritionally not replete because they're not absorbing as well. So there's also the malabsorption due to the diarrhea, and also pain where they're limited in what they can eat, in the anorexia, which suppresses their appetite. And really the best treatment to ensure that these children reach their growth potential is to treat the intestinal inflammation first. So this was a study done, in 1998-99, where basically gastroenterologists got their patients together in the UK to do a study on looking at the weights and heights at diagnosis of IBD. And you can see quite clearly here that patients with Crohn's disease are significantly more growth failing than the ulcerative colitis patients, both in linear growth as well as just in weight. So really, broadly speaking, the differences in how we as gastroenterologists can tell between the two is, as I said earlier, Crohn's disease really can affect any part of the GI tract from the mouth to the anus, whereas in ulcerative colitis, you are only talking about the colon, whereas some patients may have part of the stomach involved with the gastritis. Now, Crohn's disease is a patchy disease, so it's not continuous, whereas ulcerative colitis will be a continuous inflammation of the large intestine. In Crohn's disease, we can often see rectal sparing. This is not that often in ulcerative colitis. Crohn's disease will most commonly affect the ileum. This is not so in ulcerative colitis, apart from the presence of a backwash ileitis. Again, Crohn's disease will have perianal disease, whereas we don't see this in ulcerative colitis. The inflammation in Crohn's disease is deep and it's a transmural inflammation, whereas in ulcerative colitis, it's mucosal. We can, in Crohn's disease, get fistulae, which are abnormal connections from the bowel to other organs or the skin, and the development of abscesses. These are quite rare in ulcerative colitis. And really a diagnostic clue on histology is the presence of granulomas, which is really a collection of histiocytes that are almost pathognomonic of Crohn's, but are seen in other conditions as well, whereas we will not see granulomas in ulcerative colitis. And again, you can see narrowing of the bowel in Crohn's disease, which we don't tend to get in ulcerative colitis. Now, when we suspect a child has inflammatory bowel disease, one of the things we do, apart from history and examination, is some baseline laboratory tests. So the first thing we would look for in the full blood count is an anemia and a high platelet count, signs of inflammation. We would also look for the ESR and CRP, which is your two inflammatory markers that are most often elevated in IBD. If you have a low albumin, this is highly suggestive of IBD and more favorable of Crohn's disease. But also we want to rule out enteric infections that may be causing the diarrhea, and also celiac disease. And often with patients with IBD, we will still check their celiac serology because this can coexist with IBD. In addition to this, we would also do metabolic screens to look for any liver abnormalities. And something we now do routinely is a fecal calprotectin, because actually a fecal calprotectin in the context of IBD can be used as both diagnostic and markers of treatments and response to treatment. Apart from these initial investigations, we would do radiology investigations, and traditionally now we do a small bowel MRI, which has really superseded barium follow-throughs and negates the use of using any radiation. We still do, however, use barium for our really young children under the age of 5, just because they're not able to lie still for an MRI and will need a general anaesthetic otherwise. And also, if there is any signs of perianal disease, we would do MRI pelvis to look for any fistulas. And if there are any urgent situations where you're worried about bowel obstruction, we may do a CT. And more recently, some hospitals are superseding MRIs with high resolution ultrasounds, which can give you as much information, if not better, than these small bowel MRIs. Now, this really is our gold standard for clinching the diagnosis of IBD, and that is really using endoscopy and using our histopathology colleagues to tell us about what they see under the microscope. You can see here on the left-hand side a granuloma. So this is this pale area with a collection of the histiocytes, and this is commonly seen in Crohn's disease. Whereas on the right-hand side of the screen, you will see with ulcerative colitis, you get this crypt branching and distorted crypts, which form abscesses and are very hypercellular, indicative of the severe mucosal inflammation seen in ulcerative colitis. Macroscopically, when we do an endoscopy, this is usually what you would see in Crohn's disease. You will see this very changed, patchy, pleomorphic ileal ulcers. This is how you would see Crohn's in a cecum. So you can see sort of abscess ulceration quite deep here, erythematous mucosa filled with mucus as well. Whereas compare it to ulcerative colitis, you see this granular appearance macroscopically, mucus as well, but the ulceration is more superficial and continuous in nature. And this is a child with very severe ulcerative colitis, where you can see these almost polypoid lesions, and these are inflammatory polyps to do with how severe the inflammation has been there and for how long. Now, this is a barium follow-through, and this is just to show you the stricturing that you can see in Crohn's disease at the ileum, so this narrowed area of bowel here with an ileal stricture that you see in Crohn's disease. This is very important, is to examine every child you suspect to have inflammatory bowel disease, because perianal disease is commonly seen. We would say about 1 in 2 children with Crohn's disease may have some perianal involvement, and this can take the form of anywhere from anal fissures to anal tags to fistulae, where you can see the skin lesions and them communicating deeper, and also abscesses that can present quite painfully and require examination under anaesthetic by our surgical colleagues, and may even require drainage. Now, when we then come on to treatment, well, our goals of therapy are, we need to improve the growth and nutrition for the child. We also need to maximize their response to the starting treatment that we're using. And when we use some drugs which can be toxic, we always do this by bearing in mind that we want to minimize the toxicity of these drugs, and I will talk to you a bit about the sort of medications that we use. And at the same time, we want to prevent the normal progression of disease. So for example, with Crohn's disease, we want to prevent the presence of stricturing or fistulization. So we want to get in there early and treat the children. We also want to give them treatments that they will adhere to, because obviously when you're using combined medicines, you want to make sure that the children are going to understand it and be able to take their medicines. And at the same time, this is a chronic illness. At the moment, we do not have a cure for IBD, and therefore we want to promote their overall psychological well-being as well. And actually all of these 6 things we do at the same time, from diagnosing through to achieving remission through to maintaining them. These are the 6 things we bear in mind whenever we see our children follow up. Now, how do we assess pediatric IBD patients? Well, we have these objective markers for disease. For Crohn's disease, we have the Pediatric Crohn's Disease Activity Index, known as the PCDAI. And for ulcerative colitis, we have the Pediatric ulcerative colitis activity index, known as the PUCI. Taking the PCDI first, so this is a combination of symptoms from the history as well as objective measures, taking into account their weight, their physical, clinical examination, as well as laboratory studies, looking at their ESR and albumin. And the score can range between 0 to 100. Less than 10 means that their disease is inactive and they're in remission. If they have a PCDI of between 10 to 30, then that is indicative of some mild ongoing inflammation. And if they have a PCDI of more than 30, we're worried about this patient because we think they have moderate to severe active disease. Going on to the PUCI, well, this is just based on history taking, and it's all about the symptoms. So how much abdominal pain the child is having, the number of stools per day, the consistency of the stools, whether they have blood in the stools, whether they're waking at night to open their bowel or have the feeling that they want to open their bowel, but when they go to the toilet, there's not much that comes out, and also their general well-being and activity level. The scores for the PUCI range between 0 to 85, where less than 9 means they're in remission. A score of 10 to 34 indicates mild inflammatory disease. A score of 35 to 64 would indicate moderate disease, and a score of 65 to 85 would indicate very severe disease. In terms of the treatment, well, we used to consider it a pyramid. So if we go from the bottom up, we try and use the more safer drugs first, and we do a stepwise approach depending on whether these drugs are failing or whether or not the child is being managed on these therapies. So first and foremost, and something that's not on this pyramid, is enteral nutrition, which I'm going to talk to you about next. But really at the bottom here for Crohn's disease would be enteral nutrition. And a step up from that, if the enteral diet doesn't work, we would look at anti-inflammatories. And if that doesn't work, a step up would be going on to the steroids, which have more side effects, and therefore it's a step up. And if actually the steroids are not helping you stay in remission, we would look at steroid sort of free agents that prevent you from needing repeated courses, so your immune suppressants like azathioprine and methotrexate. Failing that, we have the biological therapies, and obviously failing that at the top is surgery. Now I'm going to go through all of these medicines stepwise, and I'm also going to explain to you that now really this thought process of going bottom up is changing drastically, both in pediatric IBD as well as adult IBD, where the move now really is to personalize IBD care and take each patient as an individual and think about their disease phenotype, how we can prevent their disease being more complicated later on, and really choosing the best drug for that. So sometimes we start top down and we may start biological therapies earlier to any of the others, depending on the disease and the nature of the disease. And I'm going to talk to you about that now. So enteral nutrition, now this really is our first line therapy for the induction of remission in childhood Crohn's disease. And that's a gold standard for the entire United Kingdom and most of Europe. And actually it came about almost 30 years ago by a study that was done at the Royal London by a professor of mine, Professor Ian Sanderson, where he actually took children with Crohn's disease and compared them to children who were being treated on steroids, and found that actually these children did just as well in terms of achieving remission with the enteral diet, but actually their growth was better compared to steroids and didn't have any side effects. Now, 30 years on, despite all the research that has been done on how exclusive enteral nutrition works, nobody actually knows the etiology. We think that the mechanism of action is to do with how the liquid diet changes the microbiota in the gut. And there have been various studies that have shown children before and after the liquid diet have a completely different microbiota to when they started. And we think that there is an anti-inflammatory microbiota to do with IBD, but again, it's not clear whether this alone would explain the entire mechanism of action. Now, exclusive enteral nutrition is very advantageous because it has no side effects whatsoever. We know that it's very efficacious and it reduces the inflammation and also improves linear growth. It is most definitely effective at correcting the undernutrition that we see in Crohn's disease, and it can enhance growth, and we can give up to 150% of the daily requirements both of calories and protein. It's a low residue diet, therefore it's easily absorbed. And it's given orally, and most children will tolerate it orally. Certainly at the Royal London in the past 4 years, less than 10% of our patients have needed nasogastric tubes, and most will drink it orally. We're able to flavour these milks using Nesquik. So the milk that we use at the Royal London is Modulin, which is a polymeric feed, and we can flavour it with Nesquik, so they can have it in chocolate, banana or strawberry flavour, or they can have it plain if they like. And this sort of really has the advantage of improving the taste and negating the use of NG tube feeds. Various studies, and these are the ones that I've highlighted for you to have a look at later in your own time, that have showed how efficacious enteral nutrition is. And as I say, it is our gold standard and first-line therapy for induction of remission in childhood Crohn's. Now, moving on to that, one of our first-line therapies that we use for ulcerative colitis is an anti-inflammatory drug, and these are drugs belonging to the aminosalicylates. They are used locally to reduce inflammation in the bowel, and they work by inhibiting the arachidonic metabolism. There are various preparations, both oral and rectal preparations. We tend to, in a new diagnosis of ulcerative colitis, use both orally and rectal preparations because we want to treat the disease aggressively. We also know that when we start an ASA drug in patients with UC, we often tell the families that we wouldn't want to discontinue it because we know that it has a role in decreasing their risk of developing colon cancer in the future. Most ASAs are very well tolerated with very few side effects. They can get some GI complaints like headache and nausea, as with most drugs, but otherwise they're very well tolerated, and we monitor their renal function 3 monthly because we know that it's renally cleared and it can affect renal function. Part of the problems with ASA is that the tablets can be quite large, and for the tablets that aren't large, they're quite frequently given, so almost 3 times a day or 4 times a day to maintain them in remission, and this can cause an issue when it comes to adherence to these drugs. As they get older, there are once-a-day preparations, but at the moment these are not really used under the age of 16. Moving on from the anti-inflammatories, we have steroids. So steroids are given if a child fails enteral diet, or in severe ulcerative colitis that is not being managed with an ASA alone. So the steroids we would use are prednisolone, and if they have very severe disease and they need intravenous steroids, then we have the intravenous preparations of methylprednisolone or hydrocortisone. This can be given topically as well for perianal disease. Certainly we would reserve the methylprednisolone and hydrocortisone for complications of IBD or very severe disease. And then the less toxic steroids like budesonide can be given to children with Crohn's disease who maybe just have isolated ileal disease in a very limited area, because then it can be absorbed locally at the TI and avoid some of the systemic side effects of steroids. Now, the important thing to say about steroids are they are never to be used for maintenance of IBD. So whenever we're using steroids, it's for an acute flare of IBD or for their first presentation. And we would always want to wean the steroid course, but we would never use steroids ongoing. If we're having to use repeated courses of steroids for a child with IBD, that's when we would think back on our pyramid and want to step up treatment and add in an immune suppressant or a biologic to control their disease. And that's really to avoid the side effects of repeated courses of steroid. Antibiotics, now we do use that as adjunctive therapy in IBD. They decrease the inflammation, and they also have a role in changing the bacteria in the GI tract. I've just had a question which I'm just going to try and answer now, if I may. So the question from one of the trainees is ASA treatment our first choice? And when would we consider elemental diet in a patient? So that's a really good question. Thank you for that. So in ulcerative colitis, exclusive enteral nutrition has not been shown to be effective. So there were studies in the past, and I think at best maybe 10 to 20% of patients with ulcerative colitis showed some sort of response to an exclusive enteral diet. So actually we don't use this. So in a child who we have diagnosed with ulcerative colitis, our first drug would be an aminosalicylate, and we would use both oral and topical, so enema treatments, to try and control the disease. But having said this, depending on their PUCI, if their PUCI score is severe, so above 60, we would then also give this child a steroid. So either orally or intravenously, depending on the endoscopy and severity of their disease. So often we will combine an ASA with steroids for initial presentation. And this brings me back onto my first slide, which says the extent of colitis in children is more severe than in adults. So often our diagnostic endoscopy for UC children is severe enough to warrant the use of steroids as well as an ASA. On the other hand, in Crohn's disease, our first therapy is always exclusive enteral nutrition. And this is given over a 6-week period. Some centres do 8 weeks. We use 6 at the Royal London. It's given exclusively with no other foods. And we know that it induces remission in up to, so anywhere between 80 to 90% of children will have complete remission at the end of the 6 weeks and have no side effects. So that is always our first line therapy. The only time we would change that is if during the course of the enteral diet, the children are getting breakthrough symptoms or we're not getting control of their inflammation. And that's when we would swap them over to steroids and Crohn's. So I hope that clarifies that question, and I will move on to talking to you a bit more about antibiotics. And again, I apologize that I can't see your questions on my screen at the moment. So antibiotics, we use this often in combination with our other treatments because this decreases inflammation, and also we use it for the perianal disease in particular. So often when we see a child with Crohn's disease and they have a perianal abscess, we know that the liquid diet doesn't work in perianal disease, and therefore while they're on the liquid diet, we will often give them a course of metronidazole or ciprofloxacin, and sometimes we alternate between the two until we can get them on to more therapies to actually close their fistulas. The other thing we use antibiotics for in ulcerative colitis is for pouchitis. So this is in our children who have undergone colectomies and they have then been rejoined and they have a pouch. Often these can be infected and have really bad sort of breakthrough bleeding, which can cause a lot of symptoms. And again, for these children, we will often use antibiotics and also probiotics that have been used for pouchitis that are quite effective. Often we will combine antibiotics, so the ones we commonly use are metronidazole and ciprofloxacin, and we tend to cycle them, especially for perianal disease, because the disease takes a while to get on top of, and this can be really beneficial when we're trying to work up a child for the use of biologics in the future. Now, this is a particularly difficult area of IBD management, and it's the patient who may just have oral Crohn's. So some of you will have heard of the condition orofacial granulomatosis, and there's a lot of debate about whether OFG is just part of Crohn's disease or whether it's a separate entity. Some of our children may only have the oral disease and they present with these oral ulcers, difficulty in swallowing, and it's quite difficult to treat. And what we use are dietary restrictions. And also we can use topical treatments like tacrolimus, mouthwashes with betnosol as well as some antibiotics in there like doxycycline. And if it gets really bad, we can also inject, but obviously we work in close combination with our dental clinicians to try and manage this form of Crohn's disease, because like I say, it's quite difficult and the diets can be quite difficult to follow. So again, we also have our specialist gastro-dietitians who will continually advise these children on the dietary restrictions that they need to follow. Now, coming on to the immunosuppressants, while these do exactly what they say, they suppress the body's immune system so that it's not attacking the gut and not causing any further damage. The indications for using immune suppressants really is to avoid the child needing recurrent courses of steroids and what we term refractory disease. So if a child with either Crohn's disease or ulcerative colitis continues to get symptoms after the enteral diet or despite being on an ASA, then we would consider adding an immune suppressant. For children with fistulating Crohn's disease, we know that the liquid diet will not work. We also know that steroids don't work because they're often infected, and you would not want to give steroids in acute infection. So again, an immune suppressant for a simple fistula is exactly what this child would need. So for perianal disease, for orofacial disease as well, biologics and immune suppressants can be used. And ongoing for children just to maintain their remission. So these are children who have frequent relapses and they're not been maintained. We would then step up and add an immune suppressant. The two immune suppressants that we commonly use are azathioprine or methotrexate. Both can give you all kinds of GI symptoms like nausea, unexplained rashes, fevers, myalgia. Azathioprine is used once a day and it's given orally. Sometimes we can split the dose if the child is having a lot of nausea, but we always warn these families that it takes at least 3 months to start being effective. So often if the child is frequently relapsing, we would give them a course of steroids to bridge them to the dose of azathioprine, or even repeat the enteral diet in children with Crohn's. Methotrexate is a once-weekly dosing regime. We can give it orally or subcutaneously. And again, this takes up to 2 months to really start to work. Now with azathioprine, before we start azathioprine, we would measure an enzyme called thiopurine methyltransferase enzyme, and this is what really metabolizes the azathioprine in the body so that we know that it would be safe for you to have it without having any toxic side effects, which we always worry about with immune suppressants. And one of the ways we can monitor therapy due to the metabolism of azathioprine is by also measuring the 6 TGN levels in the bloodstream. So that's a way to monitor whether or not the azathioprine dose is toxic. So I've talked about this. We would always do a blood test for a TPMT to guide us on the dosage of how we start azathioprine, and usually we start a dose of about 2 to 2.5 milligrams per kilo. We would always explain to the patients that they're at risk of catching infections and risk of bone marrow aplasia, and therefore initially these children would need to have 2 weekly blood tests for the first 2 months, thereafter have monthly blood tests for the next 3 months, and thereafter every 3 months. They would have ongoing blood tests to monitor their kidneys, their liver function, and their full blood count to make sure they don't have falling white counts or any deranged liver or renal function. We also then continually at 6-month point would measure their 6 TGN levels because we want to make sure that the dose they're on is not toxic, and therefore we would either reduce the dose, or in adults sometimes they can add in allopurinol as well. So basically if a child is on these immune suppressants, they need very close monitoring, both clinically as well as serologically. Moving on from the immune suppressants, we have the biological treatments, and this really has been a cornerstone breakthrough in pediatric IBD and IBD in general, and has prevented the need for using surgery in a lot of children. So we know with intestinal inflammation that the anti-TNF molecule is involved, and this is the anti-TNF alpha that mediates the cytokine pathway in causing intestinal immune reactions. So actually, how do our biological agents work? Well, they are blocking the pro-inflammatory cytokine TNF alpha, which we have proven is elevated in IBD patients, and therefore they're neutralizing the cytokine pathway in inflammation. They are highly effective drugs to treat moderate to severe IBD. We have 2 on the market at the moment, infliximab, which is 75% human, and Humira, which is a monoclonal antibody that is completely human. They both work in exactly the same way because they block the anti-TNF alpha pathway. But before we start these biologics, again, because of the side effect profile, we need to screen patients. The first thing we would screen for is the potential for latent TB infection, and we would want to exclude this before initiating any patient on anti-TNF alpha therapy, because this can then cause disseminated TB, which has a high mortality. So we would do an ELISpot and a chest X-ray. Infliximab is given intravenously. In pediatrics, it's given cautiously over 2 hours because you worry about any allergic reactions with the infusion, particularly at the second induction dose. The induction doses are given quite close together, and there are 3 induction doses that are given at week 0, 2, and 6, followed by a maintenance dose thereafter 8 weekly. Now, the Humira or the adalimumab is a subcutaneous injection. So the good thing about this is for the older patients who don't want to have to come into daycare to have these infusions, they can just inject at home. The maintenance dose is every 2 weeks. The injectable pen devices are quite easy to use and they're not painful. But obviously the side effects we would worry about are, again, the opportunistic infections, any infusion reactions or injection site reactions. You can get skin conditions like psoriasis or other rashes that can become quite inflamed when you're using these therapies and could be an indication as to why we discontinue it. And long-term, what we always counsel our patients of is the risk of lymphoma and other malignancies, especially in combination with the immune suppressants. Now, the REACH trial really showed us about how effective infliximab was for achieving steroid-free remission. And really, you can see here that they showed that the 8-weekly regime was superior to 12-weekly dosing, and also that it had sustained remission even by week 48 compared to placebo, and more so if it was given in combination with azathioprine or 6-mercaptopurine, which is a metabolite of azathioprine and better tolerated. And this is why we often will use combination therapy to achieve steroid-free remission in our children. Other new biological agents, which I won't talk to you much about because they're very specialized and they'll only be available in a few tertiary gastroenterology centers. So newer agents that are now currently being used in pediatrics are vedolizumab, which is an alpha-4 beta-7 integrin. And again, this is attacking a different inflammatory pathway of the gut. It's very gut specific and therefore safer, and it's reported to be well tolerated. But again, it takes probably 3 to 4 months to start working before you can assess whether it's been effective. Now, the trials are mostly favorable for UC, but we have also been using it in Crohn's patients, particularly those who have Crohn's colitis. Another biological drug is the monoclonal antibody to interleukin 12 and 23, and that's ustekinumab. So that is initially given induction doses as well, and then thereafter subcutaneously by an injection. And again, this is used for refractory Crohn's disease that has failed the anti-TNF drugs. We would then step up to using this. But obviously, we will have to closely counsel the patients that if they failed one biological therapy, the chances of success with another is even lower. So by the time we're looking at using these drugs, their response rate can be as low as a third, so 30% may end up responding to these drugs. A newer drug that we have only really used in a handful of our patients, and mainly patients who are above the age of 16, is an oral JAK inhibitor drug, tofacitinib, and this is really indicated in UC only, but has been shown to be quite effective and very promising drug, especially because it's an oral drug, negating the use of having to come in for infusions or injections. So really, in the future, you've seen that I've gone through quite a lot of drug therapies that we have for IBD, and I talked to you about our pyramid of going up from enteral nutrition right up to surgery at the end, almost as though surgery is our last resort. And actually now I want to end my talk on this slide, which is this is how now we think about IBD, which is actually we're personalizing our medicine to each individual patient with IBD. It's not simply a didactic step-up regime that we follow, bearing in our mind the treatment goals, which is we want to achieve remission, we want to correct their growth, for these children to achieve their full growth. We want to avoid the complications of their IBD. So we want to stop them from progressing in future, because they're going to live with this disease for many years to come. And also we want to avoid surgery, but if surgery is ultimately required, so for example in the UCs who develop complications, then actually surgery may not be the last resort. And this is where the pyramid is turned on its upside down, where we may use top-down therapy first and be more aggressive to use the biologics in combination with the immune suppressants, and consider surgery early rather than late. So I think I have some questions. Humira, atypical antibody development as a side effect. Can you say more? Okay, so somebody's asking me a question about Humira antibodies, and can I say a bit about this and what this leads to? So I'm going to talk to you about this in my cases, if that's okay. So I'm going to come back to this question. And a lovely question has just come up on how do we choose which biologic agent to use? And that's really a great question, because it brings me quite nicely to this slide that I'm showing you now about our pyramid that's turned upside down. And that's how do we decide which child needs a biological therapy first and which one? So the first thing to say, which is quite an easy answer, is the first biologic our children will get is always going to be an anti-TNF alpha at the moment. So it'll either be infliximab or Humira. Now, I say at the moment because watch this space. I think with improved research and the more patients we trial on biologics such as vedolizumab, it may be that some of our ulcerative colitis patients may get vedolizumab before the anti-TNFs. But currently, at the moment, we use the anti-TNF biologics first if we're needing to treatment escalate. Now, how do we decide whether they have infliximab or Humira? Well, this in a way depends on both the clinician and the patient choice. So, for example, because they work in the same way. So if our patient would prefer to be at home and have their medications at home, then, and they're older, they're able to safely inject, we would probably give them Humira. But if they are younger patients, we're worried that they won't be able to tolerate the injections. We also want to monitor their disease better. We would probably do infliximab. My personal preference, if they have perianal disease, is always infliximab first, and it's only if they lose response to infliximab or develop antibodies that I would then switch them to Humira. And I'm going to illustrate this, these sort of treatment questions to you in my slides as I go on. I've got more questions also about what dietary restrictions are commonly made for oral Crohn's. So we do a benzoate-free diet. That's the commonest dietary restriction. So anything with the benzoates are restricted. And I think that's it for now in terms of questions that I can see. So I'm going to move on, because I've just got 15 minutes to talk to you a bit about my cases, which I think is really quite important because they give you a feel of everyday situations and how we manage them. And ask me questions, because I've actually got one of my trainees feeding me the questions because I can't see them myself, so I will try and answer all of them. So first things first, this is a true case, a 9-year-old girl who has established diagnosis of ulcerative colitis, and she comes into our accident and emergency department with bloody diarrhea for the past 2 days. She's going 8 to 10 times a day, including and at night. She's also got these low-grade fevers. She's not gone to the school, and this is before the lockdown. So this is a case that I took from pre-lockdown cases of where she was not going to school because the pain was so bad. So I don't know how we're going to do this, but my first question was going to be what I ask all my trainees. So when I'm at the end of my phone and they're telling me this history of a UC patient who's got bloody diarrhea, really unwell looking, the first thing I will always say is, what is her PUCI? Because as I said before, this is an objective tool that tells me about her disease status, and it's all based on the history. So given what I said before, what would you estimate her PUCI would be? So given A is mild, 0 to 9, or A is remission, 0 to 9. B would be mild, 10 to 34. C would be moderate. And D, a score of 65 and above, would be severe. So how many of you would think it's A, B, C, or D? And I'm going to give you a few moments to think it over yourself, and then I'll give you the answer. And then I've got questions while you're thinking about this. So what is the compliance like on the elemental diet? So the compliance to elemental diet is a difficult one because we never really know, are they compliant? But what I can tell you is in our unit here, the compliance is very good because by 2 weeks into the enteral diet, we bring them for a clinic review. We repeat the markers. By 2 weeks into the diet, most of the CRPs normalize. Then most of our children will have gained weight. And certainly by the end of 6 weeks, between 85 to 90% will be in remission. So by inference, their compliance is extremely good, because what we find is because the children are tolerating it and feel better on it, they continue to drink it. Because if you think for 6 months preceding their diagnosis, whatever they were eating was causing them pain, and therefore the modulin makes them feel better, and they do take it. Not to mention their parents also will tell us if they're not being compliant and cheating. So good. So now in terms of this, most of you have gone for C and D, which is fantastic, great. I don't blame you for going for C because I didn't really give you the breakdown, but just so you know, this is severe colitis. This would be D, so the answer is D here. Moderate to severe, really severe, because she has got lots of, so she would score for pain that cannot be ignored, she would score, 15, she would score for extra intestinal symptoms with the pyrexia, she would score another 15. The fact that she's going at night, she would score another 10. The fact that she's going more than 8 times a day, she would score another 10. She's also got interference with the daily activities, that's another 10. So this is a really severe case of ulcerative colitis, and so the answer to this is D. Now you then go on to your physical examination, and this girl is in pain. She's also hot. She looks pale, so when you look at her conjunctiva, she is anemic. She doesn't have any palpable lymphadenopathy or clubbing, but her abdomen is full and very tender to touch, and she has guarding. So she's actually got some signs of peritonism, but she does have bowel sounds. So this is one answer I want, which is, what is your most appropriate step? What would you do in A&E with this girl? Would you carry out some blood tests and some stool tests looking for infection and admit her to the ward for close monitoring? Would you, on the other hand, order an urgent abdominal x-ray because you are worried about toxic megacolon? Would you call your surgical colleagues and discuss this with your consultant on call, and then perform the screening blood test, the stool test, and arrange urgent admission for intravenous steroids? Would you give her analgesia, perform the blood test, stool test, and start her on oral steroids? Or would you, on the other hand, reassure her, say it's infective, send stools, and discharge her with advice to call back for the results? I'm hoping you all, and you have, I've been told by my reliable trainee here that most of you have gone for B, and absolutely right. So this is a girl that you have to worry about toxic megacolon. She's peritonitic, she's febrile, she's got acute severe colitis. You absolutely, even before you call your consultant on call, get the abdo x-ray, call your surgeons, that is not wrong. Involve them early. And this is what you want to avoid. And this is a picture of a very dilated colon. And you just don't want to see this in a child. We measure it, and when we have a child who's got toxic megacolon, you get the surgeons to lay their hand on their tummy. Now, the important thing here to say is these children are at very high risk for an emergency colectomy, but, and there's a big but here, they don't all end up having colectomies. You can still admit them to the ward and start them on intravenous steroids with serial abdominal x-rays, measuring their dilated loop of bowel, hoping that it will start to shrink down with the intravenous steroids. And this is why you will closely involve the surgeons very early on, so that they can be monitoring this child on the wards. We tend to monitor them for 3 days on intravenous steroids before we then make the decision for whether or not, if things are not improving, if their markers of inflammation are not improving, whether they need to have an urgent colectomy. Obviously, the other complications of UC I've labelled here are perforation, obviously, and that's what you would worry about, hemorrhages, long-term colonic cancer, and then with ulcerative colitis, we worry about liver disease, because often they can get primary sclerosing cholangitis, and that can coexist with their UC. I've talked to you about skin lesions like pyoderma, erythema nodosum, uveitis, scleritis. So these are all the extraintestinal complications of UC that to bear in mind when you're looking at a child who presents to your A&E. Now, case 2, and I've got 10 minutes. I hope you guys won't mind me maybe going a bit over, because I think this is really important to go through some cases. So you are the on-call pediatric gastroenterologist, and you get a phone call from the DGH about Harry. He's 8, he's coming to A&E. He's had 8 weeks of abdominal pain, diarrhea, weight loss. He's lost 3 kilos in the last 8 weeks. He has a family history of Crohn's disease. His BMI is extremely low of 14. He's anemic with a HB of 7, low hematocrit, high platelets, high inflammatory markers, and an albumin of just 24. So the local pediatrician is asking you what you would recommend before the child comes over to you. So what would you do, A, B, C, or D? I'm not going to give you much time on this because I think this is quite easy. The answer for this is most definitely A. You will want to stabilize and monitor the child. We would arrange a blood transfusion. So this is interesting. I had some answers to B, so I'm going to go through all of these questions with you, okay? So, and remember, some of my answers have not been full, and I don't think MRI is wrong, but I'm going to talk to you a bit about why it is wrong in this context. So the right answer is A. We would want to arrange a blood transfusion for this child because anything under the target of 8, we tend to transfuse up. Otherwise, they can decompensate. We would always send stool samples for because of fecal calprotectin, and that's for disease monitoring as well as diagnosis. We would also at the same time send stool for cultures and virology, because this is the first assessment for a child with any form of chronic diarrhea. We want to exclude infective causes of bacteria, viruses, and parasites before we want to investigate for suspected IBD. The baseline calprotectin is very helpful to get a diagnosis of IBD because it will be used for follow-up monitoring. So that has to be the gold standard. And don't forget, this is in the context of this child being in a local DGH. The reason MRI is wrong here is because MRI in a DGH may not have the same protocols that we would use to look for small bowel disease. Also, the MRI can be performed once the infective causes have been ruled out, when we have a high suspicion of Crohn's disease based on our clinical and endoscopic assessment. Now, yes, absolutely, I got a very good question, which is, would you send a TPMT before the blood transfusion? And I got this question from trainees in North Middlesex, so bravo, well done you. Absolutely, 100% yes, please. You would do a TPMT before giving this patient blood transfusion, because once they've had a blood transfusion, very difficult for us to do this blood test for another 3 months, and then we won't be able to start things like azathioprine. So yes, please, and we would often advise that anyway. Now, wireless capsule is definitely wrong because it shouldn't be performed as a first-line investigation in this context. It can be appropriate later stage based on the findings from your first and second line tests, but certainly not first line. And then lastly, upper and lower GI endoscopies is wrong because although GI endoscopy is the gold standard to diagnose IBD, again, infective causes have to be ruled out before endoscopic investigations or diagnostic tests for IBD are initiated. Therefore, please just always remember infection and a baseline calprotectin. Very, very useful. And this brings me to an echo statement that I've kind of highlighted here, and it's a take-home message that in patients with luminal Crohn's disease following induction therapy, calprotectin is a very good marker for treatment response. So bear that in mind as we go on with this talk. Okay, so let's move on with this patient. The child is then investigated, so that we suspect that this child has Crohn's disease, and so the child then has an MRI. It shows thickened walls and enhancement with a 10 centimeter segment of TI, very hyperintense signal at the ileocecal valve, which basically means we think the ileocecal valve is also inflamed with disease. But importantly, the child has no small bowel dilatation upstream, so not at risk of any stricturing. So what do you think our induction treatment is for this child in view of how the child presented and in view of the endoscopic and histological findings? Endoscopy basically showed patchy ulceration as well. So what do you think our first line therapy would be? in the context of what we've gone through. Would you give a reducing course of oral steroids? Would you give a course of exclusive enteral nutrition? Would you use an immune suppressant? Or would you go top down and start a biological therapy? Super, super. So you have all gone for the right answer, which is B, exclusive enteral diet. And that is the right answer because, and I'm going to, oh, good. I was just going to go through it. Somebody's also just texted me A, and that's good. So let's go through induction treatment for this child. And remember, I put in view of the age, in view of the presentation, histology, endoscopy, everything. And I've put here in brackets, mark all appropriate answers. So actually, I'm going to give A as correct. A reducing course of oral steroids is correct because it's a possible effective option for induction remission in pediatric Crohn's. It's not our first-line therapy, but actually it can be. EEN is definitely preferred as first-line therapy. It's highly efficacious. It improves the patient's nutritional status and also protects the child from side effects. But actually, you can also give this child steroids. So I would accept A and B. What I won't accept is C, because thiopurines and methotrexate are maintenance treatments. They are never used for induction or remission. And again, nobody said this, but I also would have accepted D, because I've just spoken to you about the pyramid and turning it upside down. And actually, biological therapies can be correct. A top-down approach, offering biologics as induction treatment, would be justifiable in this case, because this patient is very young. And actually, despite the absence of macroscopic panenteric disease, the child does have growth failure. And while you are considering exclusive enteral nutrition, you would at the back of your mind be thinking, this is quite severe Crohn's, very long segment of small bowel disease, and actually in the end this child may need a biologic. So this is what I meant about personalizing your medicine and thinking in the future how this child's Crohn's disease is going to present and complicate their life. And actually in Harry, I would say biological therapies must be considered. So I would also mark this as right. And these are the echo statements. So in children with active luminal Crohn's, dietary therapy is our first-line induction remission. But actually, if it's not an option, steroids can be considered. And this is really important. In new onset patients with a high risk for complicated disease, anti-TNF therapies for biologics can also be recommended for induction of remission. Okay, so moving on, Harry then has a MRI pelvis performed because he has some perianal disease. And this shows that he has an intersphincteric fistula, and it's arising from the 12 o'clock position and extending. And it's horseshoe component. So I'll explain what a horseshoe means. It basically means this is a very complicated fistula, and it's coming out at 6 o'clock, and it's a very, so it's not a simple fistula that just goes in and out in one tract, but it's branching, which gives this horseshoe type appearance. So basically, Harry has got complicated fistulating disease. So now that you know this, how would you change your therapy? Would you change it, in fact? Would you, yes, continue azathioprine, prescribe a course of antibiotics to treat the perianal disease? Would you continue azathioprine and insert acetone to drain the fistula? Would you continue azathioprine and start infliximab? Or would you actually stop azathioprine and start infliximab? So this is Harry, who has progressed on to needing an immune suppressant in view of his severe disease before. But how would you now, with the azathioprine, change your treatment, giving the MRI pelvis finding? A, B, C, or D? Yes, being definitely the answer. So I've got lots of A's and D's. Anything else? Okay, good. Fine. I would say the answer to this, I would, yeah, so A and D, fine, perfect. Okay, so he's got complicated fistulating disease. Ah, okay, so somebody's giving me the answer I really wanted. Anything else? Someone's just given C. Anything else? No one's going for B. No. Okay. So let's go. Okay, I've now got changes to A and C. So let's go through this. Let's just go through this. So I've talked to you about the fact that we gave him azathioprine because he had severe disease and we knew he would need an immunomodulator. Now let's go through the ABC option. So once he's on azathioprine, we know he's got complicated horseshoe fistula. What would you do? The first one is, would you give azathioprine and give him antibiotics to treat the perianal disease? And actually, no. I would say no to this because the MRI pelvis has not identified any abscess that is drainable. So I don't think antibiotics are going to be required at this stage because, you know, if you're not draining any abscess, you're not seeing an abscess, what are you giving the antibiotics for exactly? He's already on azathioprine. So actually you then come to 2, which some of you said B, continue azathioprine is acetone. Now this is where that MR pelvis is really important. There's nothing to drain. So he doesn't have an abscess, he doesn't need acetone, he doesn't need surgery. So I would say A and B are definitely the wrong answer, which is why I was really happy when somebody gave me the answer C, because this is 100% right. He has a complicated fistula, so azathioprine on its own is not going to close this fistulating tract. He needs to commence infliximab. And this is to treat the perianal disease alongside his relapsing luminal disease that is probably feeding his perianal disease, okay? So this has to be the right answer. So it's C, it's not A or B. None of you went for D, I'm glad, because you wouldn't stop the azathioprine, and this is going back to that Reed study that said infliximab works better with azathioprine, so we use combination therapy, which is proven to be more effective than using monotherapy alone. So is that okay? Any questions with that? And I'm going to go with my statement, which is in patients with fistulizing perianal disease, anti-TNF therapy is recommended as primary induction and maintenance in combination with antibiotic therapy and surgical therapy if there's an abscess, if there is something that needs draining. Okay, and this is where the MRI pelvis is really helpful. Okay, let's move on. So unfortunately, during the infliximab that he comes in for, he then develops this allergic reaction, which I told you that patients can sometimes get. He gets a skin rash, he gets shortness of breath, he gets lip swelling, so really quite bad, and we end up giving him adrenaline, hydrocortisone, Piriton. So the question to you is, what therapy would you now consider at this point? Would you switch to a different class of biologics? And I've put here, to give you a clue, there may be more than one answer. Please mark all appropriate answers. Give you a few minutes. I know I've gone over time, I'm sorry, but I think I'm nearly at the end. Okay, so what do we think? A, B, C, or D? And I'll go through each one. So I've got some B, C, and D at the moment. B, C, and D. Okay, so let's go through these. What therapy would you consider? So he's had an anaphylaxis reaction to, so B, C, and D. Nobody's going for A. So would you change therapy? No. When patients fail to respond to infliximab, there's no evidence that other biologics would be more effective. So that's the wrong question, and nobody's gone for it, so great. A switch to a different anti-TNF is a valuable option because he's had an anaphylactic reaction. You would never want to continue it. So that's, you've lost response to infliximab. So what you could consider is adalimumab. So C could be correct, because a switch to a different anti-TNF is a valuable option, particularly in view of the fact that he's had anaphylaxis to infliximab. And you will remember I said infliximab was 75% human, whereas adalimumab is 100% human. So the anaphylaxis rates to adalimumab is less than infliximab. So this could be an option. So C is definitely an option. Now, for those of you who went for B, I would say that's not quite right, because I've put here ustekinumab is more effective than vedolizumab in treating pediatric Crohn's non-responsive to anti-TNF. Now, actually, to date, there are no head-to-head trials comparing the effectiveness of ustekinumab and vedolizumab, so there's no formal recommendation at present to support the use of one drug over the other. So I would say B is no, but then that brings us on nicely to D, which is vedolizumab or ustekinumab, and that is correct. So in pediatric patients who have moderate to severe active Crohn's, who have failed an anti-TNF or lost response or are intolerant to anti-TNFs, then you could change a biologic to either vedolizumab or ustekinumab. And I think that could be right. So the answers to this are C and D. Any questions on that? Okay, good. Let's carry on. So Harry's then switched to ADA and he's monitored monthly, but actually he's never really getting better with adalimumab. His fecal calprotectin at the end of his 4th month is still high at 340. Incidentally, let me talk to you about levels of fecal calprotectin. For a diagnosis of fecal calprotectin, I would be looking at a value greater than 250 because it really needs to be quite high. So anything less than that, I'm not that worried and I would just repeat. But once you have established IBD, then values above 150 I'd be keen to try and get on top of. Okay, so his is 340 here, and his trough level for ADA. So this is where I was saying I'm going to talk to you about levels for adalimumab. So therapeutic levels for adalimumab are high. You would want a level between 8 and 12 maybe. So his ADA levels are very good. He's a 10, and he has no antibodies. So his body's not reacting, and you know he's got a therapeutic drug level, but he's still ill. His calpra is high. He's still got symptoms. He has a reassessment endoscopy, so we will always reassess patients to get objective evidence of ongoing inflammation. And objectively, he's got persistence of ileocecal disease with ulceration in his GI tract. He also has an MR small bowel that confirms ileocecal changes, but this time he's got evidence of stricturing. So his Crohn's disease phenotype is changing, it's progressing, and he's developing complications with pre-stenotic dilatation. His MR pelvis, on the other hand, is showing that his perianal disease is improving, but his PCDAI, and this goes back to your scoring system that is objective, shows that he's got moderate disease with a PCDAI of 35. So here, what treatment options do you consider for Harry at this stage? Would you A, switch to Uster or Vedo? Would you have an MDT discussion with the surgeons to plan for a resection? I've given you a clue here. I've put mark all appropriate answers. And we are pediatricians. We always like MDT discussions. So great, you've all gone for B. I love it. But actually, A is right as well. So a switch to ustekinumab or vedolizumab is right because he has moderate to severe Crohn's. He's failed anti-TNF. And actually, he's got a presence of a stricture in view of the disease location. You know, you could actually try ustekinumab, and that's the one that I would probably do. But again, this is coming back to my pyramid where surgery is not the last ditch resort. And actually when you are, and this is something that we are as clinicians sort of at risk of doing, is because we have the biologics and we can keep trying different ones. Sometimes we delay the inevitable. And actually, I've just told you his perianal disease is getting better on the adalimumab, but actually his GI disease isn't. He's got ileocecal disease, it's quite limited. So I think an MDT discussion with your surgeons is a good thing because he could just have a limited ileocecal resection and then he could continue with anti-TNF therapy. And this is probably going to be more effective and safer than using a second-line biologic, where I've said the response to a second-line biologic is probably less effective. So I would be more tempted with B, but I don't think A is wrong either. So both to that one. And it just highlights the fact that use your surgeons and it's not a last ditch. Any questions on that? So somebody's just written about what about increasing the dose of adalimumab since his antibodies are low. So that is not correct because let me go back. I've just told you his antibodies are not low. He hasn't got any antibodies. So it's nothing about being low, but his ADA level is therapeutic. So there is no point increasing an ADA level when you've got a therapeutic level. There's no point going to weekly dosing when he's got therapeutic levels. It won't make any difference. And that's where monitoring levels come in. If you have a therapeutic biological level, there's no point adjusting dosages. It's only if you have a low drug level that would be a consideration. Okay, so I hope that clarifies that. Any other questions at the moment for that? No. So it brings me on to my summary statements. So in patients with luminal Crohn's disease, you want to reassess for transmural involvement using MRI bowel ultrasound as a marker for treatment response. So not just using lab markers, but you would want to reassess where that disease is. And all patients who have an ileocecal resection would then need to be reassessed by endoscopy between 6 to 12 months to make sure that they're not at high risk of recurrence of their disease. And again, we would want to continue anti-TNFs in these patients. So for Harry, we would continue the adalimumab. Okay, and now just a few test slides. This is a very quick, short answers, much less complicated than my cases. So testing you in children diagnosed with mild to moderate luminal Crohn's, first-line therapy for induction of remission is, and I think you should all get this. So we've gone through this, and this is just summary test to tell you first-line therapy for Crohn's disease, always exclusive enteral nutrition with a polymeric diet. Next one, well done. In pediatric patients with Crohn's who have reached clinical and biochemical remission, fecal calpur is not a useful marker to detect relapse before clinical symptoms, so you know that that's probably not right. Monitoring is aimed at early recognition of a disease flare. The interval of clinical monitoring should be 6 monthly. Or D, post-induction, a PCDI of more than 5, CRP of more than 20, and fecal calprotectin of more than 400 is unrelated to an increased risk of relapse. So again, you know that the answer here is B, monitoring is aimed at early recognition of a disease flare. There is no such thing as interval monitoring of 6 months. We monitor patients regularly depending on their symptoms, and we see them regularly in clinic. Next, in children diagnosed with Crohn's disease, the preferred method for evaluation of transmural inflammation at diagnosis and during follow-up is CT or upper and lower GI endoscopy or small bowel MRI or ultrasound, depending on the expertise, or a barium meal. And this is looking for your transmural inflammation at diagnosis. Answers to this. Lovely, B and C, correct. And lastly, in children diagnosed with mild to moderate luminal Crohn's, the use of mercaptopurine or thiopurines, A, recommended for induction of remission, B, recommended as monotherapy for maintenance of steroid-free remission, C, does not necessarily require any specific monitoring blood tests, D, is always recommended in combination with anti-TNF treatments. There's only one right answer for this one. Yes, so it's good. The answer to this is B, okay? Because remember, it's not D, because sometimes we use azathioprine alone before these children ever need to go on to a biologic. So it's not always recommended in combination with anti-TNF. The statement that would be true is anti-TNF treatments are always recommended in combination with azathioprine. So it's a bit of a catching you out there. So B is the answer to that. Next, in children with Crohn's disease, anti-TNF therapy never recommended for patients with growth failure or stricturing. B, should be recommended for patients who failed remission despite optimal use of immune modulators. C, does not benefit from combination therapy with immune suppressants. D, is recommended for inducing remission in children with moderate to severe active Crohn's. Again, there's only one right answer here. Lovely, excellent. D, so is recommended for induction of remission in children with moderate to severe Crohn's, particularly if they're at risk for progressive complicating disease. Lovely. Okay, pediatric patients with Crohn's who underwent intestinal resection. A, intestinal resection is curative, hence they don't need post-operative maintenance therapy. B, 5-ASA maintenance is superior to the immune suppressants. C, fecal calprotectin is not a reliable marker for post-operative monitoring. Or D, a normal calprotectin at 6 months post-surgery predicts maintenance of remission at 18 months. And this is just to talk to you about how we go on to observing our patients post-op. Have you given me an answer? I think you have. Yeah. Oh no. So some of you have gone for B and C. So B and C are wrong. So obviously intestinal resection can be curative, but they do need maintenance therapy, so it's not A. B is definitely wrong. So 5-ASA maintenance is never, so you guys, it's never superior in Crohn's disease. 5-ASA maintenance is used in ulcerative colitis, not in Crohn's disease. Okay, so it's never superior to the thiopurines. C, oh, I'm really sorry that you guys have gone for these. So I've just told you that fecal calprotectin is a reliable marker for postoperative management. And then D is the right answer. If you have a normal calprotectin at 6 months post the resection, then you do know that 18 months post resection, this child is probably going to be at remission. So the answer here is D. Were there any questions on that? Because obviously a few of you went for the wrong answers. Any questions? Does anyone want to ask me about that or these statements? No? Okay, good. So I've gone very over time and I'm so sorry. And thank you for bearing with me and giving me these questions. So really, I hope I've given you a good overview of pediatric IBD. It's complicated, but we really need to know about this because increasing incidence of IBD, and actually we're seeing it more and more in pediatrics. So as pediatricians, we need to recognize the symptoms, we need to recognize these patients early so that we can make a diagnosis and get them seen by tertiary specialists soon. I've also sort of hinted about the way to differentiate between the two, both on history and examination, as well as the kind of tests that we do. And really, I'm hoping that you all will have gone through with me that in terms of long-term management, although our primary goal is to induce and maintain them in remission, we also want to prevent the long-term complications of both the disease as well as the drugs. And this goes back to the pyramid of using top-down therapy early if we need to. So any questions? I'm happy to take any questions now. Let's have a look at what I've got. So I've got a question. Why do you suggest for children with known IBD presenting with flares overnight what do you suggest? Who come with known IBD presenting with flares to their local DGH? Just admit them on fluids and gut rest. Urgent discussion with the tertiary gastroenterologist. Avoid antibiotics and steroids until discussion. So Saskia, this is a lovely question, and I think I was
Hello.
Richard?
Hi, I know.
Something bad would happen. But I'm not on that team.
Hi everyone, I've got Fatima now. We can just go through Fatima. We were just saying about the child who presents to their local hospital and with IBD. Yeah.
So I would say for any of you on call, whether you're SHOs, whether you are registrars, you will always have your tertiary gastroenterologist, and we are on call 24 hours of the day. And I would directly phone the switchboard of our hospitals and speak to us for a plan. And you can do that even before you send blood tests. Now, a common theme you will find is most of these patients will need blood tests and stool tests. So what we commonly want is blood tests for looking for anemia and CRP and the ESR. We also then want stool tests for culture, viruses and bacteria. And then we also will protectants. And then you see what you can do is phone us after that. But if the child is unwell, if they're febrile, they're in abdominal pain, we would want to be called because is this a toxic megacolon? You know, does the child need an abdo X-ray? So it really depends on if it's a Crohn's patient or whether it's a UC. But as a fail-safe, always, during that night, call the gastroenterologist. Don't feel like you need to admit the child on gut rest and then call us on the day. Call us no matter what time.
Great, thank you. And another question was something about I'm just trying to find again the fecal transplant, if it's a problem with the gut microbiome playing a role in triggering IBD. So is there any role for fecal transplant?
So that's a really good question. So fecal transplants at the moment are not being done in pediatrics. There's a trial for fecal transplantation in adults at the Royal London with Professor James Lindsay, but it's a trial. So far, the trials that have used fecal transplantation have not been successful in IBD. So there's no evidence to suggest that they are efficacious. The trials where it has worked is in ulcerative colitis pouchitis. So we think some cases of pouchitis can have a fecal transplant and there is some source of relief. But otherwise, there's no real evidence for it. And the only evidence behind fecal transplantation at the moment is for C. diff infections.
Okay. Why do you think the incidence is increasing?
So the incidence in IBD, and this is really comes down to the multifactorial etiology basis of IBD. So nobody knows what causes it. We know, for example, the incidence in Western world, but also in countries such as India and China as well. And we think that's to do with the environmental triggers because it can't be our genetics. Our mutated genes have not changed. But what has changed is our environment and our bacteria, so our luminal bacteria, our defense system and our immune system's reaction to that luminal bacteria. Something that we know shapes our luminal bacteria is our diet. Something we know that shapes our luminal bacteria is our exposure to infections and antibiotics. So really, it's really multifactorial. You know, smoking, your age of onset, all of these things will play a part to why we're seeing an increased incidence. But the important thing to say here is it's not to do with our genes. I think it's more and more to do with our environment and the way our immune system is handling it.
Brilliant. And I think the final question was about psychological support that you give to the patients and families.
So I think this is a moot point for all of us because we would like more. And a lot of places, even tertiary hospitals, don't have a psychologist with a gastro team. Now, our IBD patients have chronic illnesses. They may or may not need surgeries. They may end up with stoma bags. And actually, psychology has a huge part to play in these kids and their families and how we support them. So I think they are a vital part of our IBD team. We have a psychologist in our unit who works with IBD patients very closely. But I know that funding for a psychologist is minimal. So trying to have a psychologist with every IBD unit is almost impossible nowadays in the NHS. But it's one of the things every gastrophysiologist is looking for, and I would welcome it because I think they're fundamental in the treatment of IBD patients.
Brilliant. Oh, another question. Is there anything quite different in terms of severity or management for patients who are classified as VEO IBD?
Yes, so that's something that is a talk entirely on its own. The fact that I got pediatric IBD in an hour was difficult on itself, but very early onset IBD is an entity on its own, and this is where your genetics come into play. So these are IBD patients who are diagnosed before the age of 5, in fact 3, and they are very aggressive phenotypes. So they present with Perianal Disease, they present with abscesses, they present with really severe colitis, growth failure. Some of these patients end up having stem cell transplants. So these are patients who have, some of them, identifiable gene defects. And so I would say they are a completely different entity to what I just talked about in the pediatric IBD. Now, some of the treatments they may still get, but in terms of an entity on their own, I think they are a separate entity because of their disease phenotype. And more of their etiology is explained genetically as opposed to environment.
Oh, great. And I think that is all the questions. Okay.
So all I need is 5 separate thoughts to, a lot of information is there from my talk.
Okay. I'll send everyone that link just now. Thank you. Bye-bye.
Walking, Mama.